النهارده هتكلم على two major problems, obesity and mental health disorders, how they are related, and how we as bariatric physicians should modify our treatment for such cases. First of all, is obesity a psychiatric disorder? Is it addiction for food or food dependence? There are pros and cons. Obese individuals often eat more than they intend to. Obesity can reduce an individual's ability to participate in a full range of social, occupational, and recreational activities. Many individuals continue to overeat despite knowledge that this is wrong. This is like addiction. But there are things that are cons. Food, unlike drugs and alcohol, is necessary for life that is impossible to abstain from. Psychological markers, physiological markers of dependence like tolerance, withdrawal, and craving for food are not well characterized or understood at this time. Now, is it important to modify the treatment of obesity for the mentally ill? Definitely yes, and now we speak about why. Both obesity and common mental health disorders account for a significant proportion of the global burden of disease. Obesity can lead to mental dysfunctions, and mental dysfunctions can lead to obesity. And look at these statements. Most recent systemic reviews of longitudinal studies showed that there is bidirectional association between depression and obesity, and there is a positive association between obesity and anxiety disorders. 50% of obese patients have increased risk of developing depression over time, and 58% of depressed patients have increased risk of becoming obese. But why? There are lots and lots of factors, internal and external. The gender, I need a lot of time to explain this, but I will go through it quickly. Obesity causes mental health disorders, and mental health disorders causes obesity with many factors. Say the gender, for example, males are more keen about their weight than females, so they get depressed if they add weight, and the age, many other diseases, and even the socioeconomic standard of the patient. We find obesity and bad lifestyle among the low socioeconomic standard, and depression is the same. And if we leave the obesity and the mental health disorders without treatment, we get major complications that will even make the treatment even worse. For example, as you know, there are many complications of obesity. Not the least of them is the central nervous system problems that will lead to more mental health disorders. And there are lots of complications if we leave the mental illness without treatment. So we need to treat the two conditions. And obesity with mental illness must be viewed as two chronic illnesses that necessitate long-term management without losing hope. Now, the aim of obesity management, there are classic aims, we all know, to reduce further weight gain, to induce weight loss, and to produce weight loss maintenance. But there are specific goals in such cases. To prevent or delay the onset of the mental disease. If we treat obesity, we can prevent and delay the onset of mental disease. We can improve the treatment outcome, and we can prevent complications. Let me give you examples. Over 50% of all Alzheimer's cases may be prevented through better lifestyle changes. Reducing important risk factors that increase vascular disorders will help in the management of mental health disorders. So diabetes mellitus, dyslipidemia, and increased blood pressure that become more with having more and more weight. They lead to stroke, and stroke leads to dementia with all the consequences. Let me give you an idea about improving the treatment outcome of the mental health disorder. Weight loss enhances neurovascular functions, as you all know. It enhances vascular signaling markers. It decelerates the rate of decline in cerebral blood flow in aging mice, and it preserves learning and long-term memory of aging mice. And in such a disease, attention deficit hyperactivity disorder, the promotion of healthy eating and activity should form a part of the secondary prevention and management strategies for children with such disease. Now, should we start obesity management at the very beginning of when the mental health disorder is diagnosed, or should we delay it? Of course, we should start once the mental disease is diagnosed, because there are, I will tell you how to modify the management now. And in management, I will speak about the assessment and in the treatment. Now, the assessment of obesity, as you all know, this is the regular assessment. We measure, we get the blood tests and clinical assessment, and we see the dietary intake. But there are things that are specific for such patients. We have to check the self-concept, the eating disturbances, the social problems, the stress levels, the current life situation, sources of social support like family and friends. So if you are faced with a patient who is obese and he wants to get rid of his weight, and he's taking medication for mental health disorder, is he supported by the family or friends or not? So when we look at assessment of the eating disorders that are related to obesity, such as anorexia nervosa, binge eating, and bulimia, and I will remove anorexia nervosa from here because they are not obese patients, definitely, as you all know, but they come to us thinking that they are obese, and they insist that we give them diets. And when we don't give them diets, they might kill themselves by not eating. So that's why anorexia nervosa is mentioned here. As you all know, in anorexia nervosa, there is a refusal to maintain body weight over the minimum normal weight for age and height. There is intense fear of gaining weight or becoming fat. There is disturbance in the way in which one's body weight, size, or shape is expected, or there is a denial of seriousness of low body weight. They deny that they are unsafe when they are having such very low weights. In females, there is absence of at least 3 consecutive menstrual cycles. So we should look at all this and we should ask for this. And when we speak about binge eating disorder, those have episodes that should include one of these factors, at least three of these factors. Eating faster than usual, بياكلوا بسرعة قوي. Eating past the point of fullness, بياكلوا بعد ما يكونوا شبعوا. Eating when not hungry, even when they are not hungry, they eat. And eating alone in secret, they take the food and go to the kitchen and eat by themselves. Feeling upset or guilty after overeating and feeling taken over. دايما يكون حد صاحبهم عشان ياكلوا، يقول لك حد بياخدني، أنا حاسس إن أنا مش رايح بمزاجي، أنا رايح غصب عني. And there is extreme concern, abnormal concern of distress about eating behavior. There is binge eating at least 1 or 2 times weekly in at least 3 months duration, and no purging strategies in the binge eating. But they are unable to stop eating even when feeling full, and they say that binge continues until the urge of eating is gone, tension is reduced, and then satiation is reduced to the point of pain or person is interrupted. And in bulimia, there are recurrent same points like the previous points, but followed by purge. So this is, they induce vomiting, they take laxatives, and so on. These are the bulimia. Now, when we speak about the classic treatment of obesity, we spoke about the assessment. We will ask about all what I was mentioning now in the when they first come. But now the treatment. How to treat obesity? Of course, you know the lifestyle modification, diet, physical activity, and behavior modification. Pharmacotherapy, are we allowed? Can we give pharmacotherapeutic agents for obese, mentally ill patients? And how about bariatric surgery and the bioenteric intragastric balloon, which is the balloon المعدة. Now, although we individualize our treatment for obese normal patients, but the mentally ill, research shows that these people who participate in groups lose more weight than doing it alone. So although we treat the normal patient in privacy, yet in mentally ill patients, if we put them in groups and we treat them, we get better results. Now, the diet, how we modify the diet for such patients. The counseling attitude should be different, the weight loss aims are different, the macro and micronutrients should be modified. Now, the counseling attitude, they come to us every week, and during this, we work with the individual and the family. So we ask the family to come with them, the husband, the mother, the kids, and so on. We discuss about the history and concerns. We discussed this before in advance. The goal settings should be very specific and ambitious, okay? And monitoring, how to monitor these patients. And then in the weight loss, we have to consider that these patients are being treated to lose weight. But for the weight loss, there is something different about these patients. We cutting down of portions while eating the same food. At the very beginning, we should not ask them to eat the very regular food that we give, the very healthy food, but we ask them to reduce what they are eating because it's not easy to make them just shift from the bad lifestyle, the bad eating to a perfect one immediately. Then we give healthier, we start giving healthier diets. So we don't give the healthier diet from the very beginning. We accept some bad healthy eating pattern, and then we reduce the portion, and then we introduce the healthy eating habits, and we avoid restrictive diets. We shouldn't say that this is not allowed. It's better to be avoided. We adopt new habits that foster a healthier lifestyle. We ask them to eat less, not to binge that much, and so on, and not to attempt radical changes. I mean, if I say this is not allowed, he will not come again. We can say it's not good to do this that often. You should reduce your binging, for example. Now, the diet content, we have to specify that these items, these ingredients should be considered. We increase the omega-3 fatty acids, we reduce the omega-6, omega-3 ratio, we increase antioxidants in the food, probiotics, fruits and vegetables, reduce processed foods and sugar, increase fibers, and increase complex carbohydrates. And this is, the pattern of the Mediterranean diet, very suitable for such patients. Now, there are certain procedures that we have to go to do for anorexic patients. Although, as I said, they are not obese, but they come to us and they insist, and they say, I will pay my money and I have to see the doctor, even I say, don't let him in. Anorexia nervosa cannot be treated unless the weight is stable. So if they are still losing weight, that cannot be treated. We should engage the patient. We should give the patient the responsibility of the success of the treatment. We should understand their very resistant attitude, and we re-establish healthy control with appropriate resources, and we facilitate family therapy if possible. That's important to have, although they come without the family, but we have to ask them to and try to bring the family. And we have certain procedures that we have to do with the obese binge eater. We agree together on eating guidelines. We agree that you should eat so and so, you should reduce so and so. So there are new guidelines for eating for him. We should allow sufficient calories distributed throughout the day, because remember, he wants to binge. So if I say you just eat 3 times, how about in between? He's not used to having nothing in between. So we should allow the calories to be distributed, say, every 2 hours. No long gaps, of course. No weight loss before healthy habits are well established. I mean, if I could maintain the weight, not to lose any more weight, then we can start later to give healthy eating habits. We have to use diaries. The patient should write what he eats, what time he eats, and because this will help me design for him a better diet. We should consider weight loss after about 3 to 6 months of binge-free eating before you can think of stopping the diet. Now, the bulimic, we do the same, but we give more information about the drawbacks of inducing vomiting or having laxatives. And of course, number two in the treatment of obesity is exercise. There are no contraindication for asking these patients, so the mentally ill patients, to come for exercise. And exercise improves both the physical and mental health and well-being of individuals, even if they have schizophrenia. Now, behavior modification. This has to be done, and we have to stress on that. And it has to be done by specialists, psychologists, for example, because, as you know, good habits, if we could put them in the patient, then they can live healthy for the rest of their lives. Now we come to this crucial part of the management of obesity. Shall we give them the regular medication? And number one, what are the regular medications? Do we have lots of medications? No, we only have 6 worldwide. 3 of them are only in America, and we only have 2 here. Phentermine is not allowed. Cusimia is not allowed. Belvic is not allowed. Contrave is not allowed because of these work on the brain. Even Orlistat, that does not work on the brain, is not allowed in anorexia nervosa and bulimia. And even if we look at the liraglutide Saxenda, we find that there are warnings about if the patient gets suicidal ideas, then we have to stop the treatment. Although Saxenda can be used, the BIB, the intragastric balloon, the biointragastric, is absolutely contraindicated in psychiatric disorders. And how about bariatric surgery? Patients with psychiatric comorbidities should not be excluded from the procedure if adequate postoperative support is provided. The bulk of evidence shows no relationship between psychiatric disease and total weight loss after bariatric surgery. And the Maestro, which is the machine that we put for the patient to reduce the hunger, there is no specific contraindication for use of Maestro in such patients. So what do you think? Is any of the mentally ill patients should be excluded from obesity management? Of course not. The medications that they take are inducing more and more obesity with the vicious circle again. And in conclusion, obesity and mental illnesses are very interrelated. There is a this relationship is bidirectional. Obesity and mental illness are serious chronic diseases necessitating long-term treatment, and obesity management should be a routine practice in the mentally ill patient. Modifying the classic management of obesity is a must in such patients, and thank you very much.